Subtrochanteric fractures. Anatomy. Subtrochanteric fractures occur below the lesser trochanter, LT, of the femur, typically within 5 cm distal to it. Classification. 1. Fielding classification, based on the location of the primary fracture line relative to the lesser trochanter. Type 1. At the level of the lesser trochanter. Type 2. Less than 2.5 cm below the lesser trochanter. Type 3. 2.5 cm to 5 cm below the lesser trochanter. 2. Sainsheimer classification, based on the number of major bone fragments and the location and shape of the fracture lines. Type 1. Non-displaced fracture or displacement less than 2 mm. Type IA. 2-part transverse femoral fracture. Type IB. 2-part spiral fracture with the lesser trochanter attached to the proximal fragment. Type IIC. 2-part spiral fracture with the lesser trochanter attached to the distal fragment. Type 2. 2-part fractures. Type IA. 3-part spiral fracture in which the lesser trochanter is part of the third fragment with an inferior spike of cortex of varying length. Type IB. 3-part spiral fracture of the proximal third of the femur with a butterfly fragment. Type 3. 3-part fractures. Type 4. Comminuted fractures with 4 or more fragments. Type 5. Subtrochanteric intertrochanteric fracture, including fractures extending through the greater trochanter. And 3. Russell-Taylor classification. Type 1. Fractures that do not extend into the piriformis fossa. Type IA. Lesser trochanter is attached to the proximal fragment. Type IB. Lesser trochanter is detached from the proximal fragment. Type 2. Fractures extending into the piriformis fossa. Type IA. No significant comminution or fracture of the lesser trochanter. Type IB. Significant comminution of the medial femoral cortex and loss of continuity of the lesser trochanter. Treatment. 1. Conservative management. Indications. Unfit for surgery, children. Methods. Traction in 90 to 90 position for 8 to 12 weeks, followed by hip spica, cast brace. 2. Operative management. Indications. Most fractures, including those with significant displacement or comminution. Methods. Intramedullary nail, IMN. First generation, centromedullary, if both trochanters are intact. Second generation, cephalomedullary, for all fracture types, with either a trochanteric or piriformis entry point. Fixed angle plates, 95 degrees. DCS, dynamic condylar screw. Blade plate. Proximal femoral locked plates. An alternative to fixed angle plates. Dynamic hip screw, DHS, not the preferred choice due to its limitations in this type of fracture. External fixator, used for open fractures or highly comminuted fractures. Complications. Malunion, common, fractures may heal in varus or procurvatum deformity. Non-union, delayed or absent healing. Implant failure, can occur due to improper fixation. Atypical femoral fractures, associated with bisphosphonate use, which may weaken the bone. Key points. Proper classification is essential to guide treatment strategies. Conservative treatment is reserved for children or patients who are not candidates for surgery. Surgical management involves various options, with intramedullary nails and fixed angle plates being the most common methods of fixation.